everyone, and thank you so much for logging in and attending our webinar. Hopefully we'll have some exciting information today and we'll have a chance for question and answers at the end. So the reason we're discussing newborn screening today, because it's an important topic, and our objectives for the program is to talk about changes in newborn screening as they relate to the neuromuscular disease, whether it's on the national level or the state level. Also understand why we need newborn screening and how important it is, and how important it is to help families prepare for the next steps in care and understand the disease. Also, to anticipate care challenges based on the changes in newborn screening and available therapies that are becoming more and more available nowadays. And also, we would like to incorporate the knowledge of newborn screening into the practice in patients, and when we care for patients with neuromuscular disease, and to inform care needs. So whether we need more diagnostic testing, communication with families, more therapies. So I think the newborn screening program is an essential program, and that's why we would like to discuss this today. So newborn screening and neuromuscular disease have become available since at least 2016. The main objective for newborn screening is to maximize benefits and preserve function in patients with neuromuscular disease. So why does it matter? Because we know that many of the neuromuscular disease cause irreversible and progressive muscle damage and loss, which eventually will lead to loss of ambulation, contractures, and also significant complications related to the disease. So early identification through newborn screening can enable us and enable families to process and plan for care needed for each and every different disease. And especially, most diseases will have a multidisciplinary approach and also multidisciplinary care needs based on the disease itself and the patient. And this will also, newborn screening will allow you to connect earlier to care specialists and centers that can be familiar with the rare disease and also offer different treatment options. And this will allow us to offer the treatment options that are available today. So the process for newborn screening to be implemented in every state or even on a national level is a little bit complicated and takes years to include a disease on the newborn screening panel. And this is a federal government program. So on the national level, there is an entity called RUSP, or Recommended Uniform Screening Panel. And it's a panel that actually includes families and also experts in the field that and government officials that will discuss, which is the next disease we're going to include on the newborn screening. So it's through the U.S. Department of Health and Human Services, and they usually recommend conditions based on the following: whether or not there is an available test that is sensitive and specific to make a diagnosis in a certain neuromuscular disease, and the test has to be also affordable. So it has to be available, affordable, and easy to interpret. And also if the disease itself has a benefit of early identification. So whether or not we can offer treatment, whether or not the early identification can prevent further complications such as a metabolic disease. So we'll need, more urgent intervention. And now that we have treatment options available, it will definitely be of use in patients with neuromuscular disease, especially the earlier we can offer these treatment options. Now, once the federal government decides on which disease can be included on the RUSP, then it comes down to the state level. So each state will have to actually consider which test to include on their newborn screening. And that usually comes back to a panel and also another group of experts, including physicians, families, that will discuss with every state health department, which one to include next. And sometimes it's a financial decision based on the state availability and possibility to add it. So the state can select which conditions and implement mandatory newborn screening based on these facts. And they do not many states do not screen for all conditions that are on the RUSP. So you may be living in one state, but then across the street, the other state may not be screening for a certain disease, like whether it's neuromuscular disease or not. And then when it first starts, also not all states will implement it at the same time. So like in Pennsylvania, we're bordering like Ohio, Maryland, New York. And so we have to be aware as physicians, where is the patient coming from and whether or not they were actually potentially tested for a certain disease on newborn screening. They can also encounter delays. The states can encounter delays in implementing GRASP-adopted conditions. As I mentioned, usually it's either financial, also comes down to the medical centers, whether or not they're willing to implement this because it's an added burden on the newborn screening process itself. And you may or may not be familiar, but newborn screening is available in all states for other diseases other than neuromuscular disease, which is a blood spot that is taken from the baby when they're first born, and usually the results come back within a week or so. So adding more testing or adding more diseases to this newborn screening requires also familiarity with the how to obtain the spots and also how to interpret it. So once we have a newborn screening result that is positive, we need follow-up genetics and a genetic evaluation, obviously, along with the medical team and, of course, to include the family. So the molecular genetic testing after confirmation of a positive newborn screen result is typically recommended for all diseases. So once the newborn screen result is available and let's say there is a positive result, and it's usually communicated to the patient pediatrician. So imagine the baby is born in a hospital, and then the newborn screening is obtained. Usually before the baby leaves the hospital, there's a pediatrician that's identified. So once the lab screening happens, and if there's a positive result, then there's a newborn screening coordinator that is becomes aware of the results, and they usually communicate it to the pediatrician, and the pediatrician usually begins coordination of the care. And in this case, with neuromuscular specialists, since we're discussing neuromuscular disease, and that neuromuscular specialists will usually reach out to the family and recommend in-person visit to provide education about the diagnosis and obtain a confirmatory test. So usually the confirmatory result is obtained in that first visit, at least the confirmatory blood sample that is required for the confirmation of the results is usually obtained in that first visit with a neuromuscular specialist. And to discuss what is the disease, what are the treatment options that are available, and what is the next step after this presumptive newborn screening result. So today we're going to focus on two diseases. One is SMA, and then the second is Duchenne. So we're starting with the newborn screening for SMA. So SMA newborn screening was added to the RUSP in July of 2018, and it has since been adopted by 99% of the U.S. states. In Pennsylvania, it was started in 2019. The newborn screening for SMA can identify 95% of positive SMA cases, and those are cases that have the disease. So 5% of the cases may be missed or not identified, but will require a clinical exam and further testing for the diagnosis if the clinical suspicion is high for SMA. Usually newborn screening does not typically identify carriers, but it identifies if there is a mutation on both alleles or both sides of the gene for SMN1. So when there's both deletions or absence of SMN1, that's what will be identified. So the newborn screen is diagnosing a disease. It's not a carrier status. And newborn screening for SMA is based on a technique called polymerase chain reaction, or you may know it more as PCR, which is used for many types of identification for different diseases, and detects the common SMN1 deletions, and that's again obtained on the dried blood spot that was obtained on a piece of paper when the baby was being discharged from the hospital. So it does detect deletions in SMN1 gene with a high specificity and sensitivity, meaning it's a good test, and it doesn't require a lot of blood. Now, some states can actually piggyback this on another genetic disease called SCID, and they use a different technique called multiplex or MLPA. And again, this can help identify the SMN1 deletion. So it depends on the state lab, which technique they use. Now, most state labs are, of course, certified, and even some states will share one single lab. So once we have an SMN1 deletion or an SMA identified patient, then we do confirmatory testing, which includes, again, repeating the test for SMN1 deletion, and also asking for a confirmation of the SMN2 copy. So for SMA, there's two different genes, the SMN1, which is deleted or absent in SMA, but there is a compensatory gene called SMN2, which in this case, we'd like to know the number of copies, and it should be obtained if not already performed on newborn screening. Since some states will only diagnose the SMN1 deletion, but it's on the physician or the treatment center to identify how many SMN2 copies. And the reason to try to find which genotype or how many SMN2 copies, because sometimes this can help us determine the phenotype of the patient, meaning how clinically they're going to behave or how clinically severe this disease will be. And it's important also because now we have treatment options, different ones, and some may be more suitable for different severity of the disease. So once we have a newborn screening that is positive, then we do the confirmatory test, which includes the SMN1 deletion, but also the confirmation of how many SMN2 copies we have. So we're talking about, let's say a patient has SMN2 copy number 1, which usually is classified as type 0 for SMA and usually predicted to be quite severe. So this, again, may help guide treatment. First of all, if the patient has minimal symptoms, then a discussion would be to initiate treatment as soon as possible and not to delay treatment. But if the patient is exhibiting severe symptoms of the disease, then there can be a discussion with the family and also the treating neuromuscular specialist about which type of therapy or how to manage the patient with a very severe type of SMA. Now, if the SMN2 copy number is 2, then usually that's type 1. Again, initiation of treatment has to be as soon as possible. Now, there are milder cases which have 3 copies. And again, the treatment option can be different. However, because these are babies, we usually, most neuromuscular disease specialists will probably recommend still a aggressive form of treatment or like a treatment that needs to be initiated as soon as possible, since it's sometimes difficult to predict what is going to be the clinical outcome of a patient or what their phenotype will be. Now, if we identify that the patient has a large number of SMN2 copies, then they may not even exhibit any symptoms until late adulthood. And then there can be a discussion about which treatment option, especially that some insurance can limit what is the treatment option for this type of patient. So it's essential to do the confirmatory test and obtain also more genotype clarification. So in babies who are identified with SMA, usually we bring them into the clinic as soon as possible. Once the newborn screen is identified as positive, so within a couple of days, usually they are seen in the clinic. We can discuss the 3 FDA-approved therapies that are available now to treat children with SMA. We know that any patient with neuromuscular disease, especially if it's identified early, then the initiation of treatment as early as possible usually is more effective. So we're going to go in the order of how early they were approved. So the first drug that was approved for treatment of SMA, which also encouraged, to include the SMA on the RUSP, the availability of a treatment option, which is called nusinersen or Spinraza. It's a form of treatment or a drug that is classified under the mechanism of antisense oligonucleotide treatment. It provides a genetic intervention that helps increase the number of SMN2 copies through a messenger RNA splicing modifier. So it increases the number of SMN2 copies, and we know that with the more number of SMN2 copies, there is a milder phenotype for SMA. This was approved in 2016 for children and adults at the same time. It does require an intrathecal administration, which means it's in the back below the spinal cord. There are 4 loading doses, which are usually 2 weeks apart, and then 1 month. And then the regular maintenance is every 4 months. This is a lifelong treatment and help maintain the function of the motor neurons and will require maintenance throughout the life. The second drug that was approved is omnizimonogene apoparvovec, which is Zolgensma. That's the gene therapy. So we know that the gene therapy also came into play early after the Spinraza, which was approved in 2019, and the FDA approved it for patients up to 2 years of age. That was based on the studies and also the fact that the disease is very early to be and for intervention to happen early. It is a one-time intravenous administration. It does have limitations if the patient has antibodies against this vector or the capsule that includes the gene, because this will null the treatment, will not allow it to be effective. So we definitely, there are some surveillance labs that need to be done following the infusion and very close monitoring because of the potential side effects, like with any other treatment. But however, in this case, it can be also detrimental, and that's why there will require significant close-up surveillance. Now, for the third drug that was approved, it's called risdiplam or Evrysdi. It's another small molecule, so it is closely related to nusinersen. However, it functions with a different mechanism, but the mechanism of action leads to, again, increasing the number of SMN2 copies, which, again, hopefully provides a better phenotype or a milder form of the disease. This was approved in 2020 for people 2 months and older, and it's oral, so it's given by mouth, and it's once a day. It is effective to help in the swallowing issues that can come with SMA. So we have 3 treatment options that we should discuss once there's an identified SMA baby, and all they. It's a discussion between the neuromuscular specialist and the patient's family, and also there may be some limitations based on some surveillance labs. Now, as we mentioned, so the SMA's newborn screening identifies about 95%. And even if we see a patient that can have clinical features of SMA, but if they're negative on the newborn screening, we should still consider testing and performing other tests that can help confirm the diagnosis. So even though that the newborn screening for SMA has been adopted by most states, there are sometimes missed cases. Whether it's an unusual mutation, such as a point mutation versus a deletion. So this will require gene sequencing, which is a different mechanism of testing, different from the newborn screening. And also, as I mentioned, there are sometimes SMN2 copy number may not be identified, and they are on the newborn screening, and they may require further testing, especially in patients who have more than 4 copies. That can sometimes be confusing and can fall in the category of the patient actually would be manifesting the disease or not. Now, the interpretation of the results can be sometimes confusing to maybe physicians or providers who are not familiar with the wording of the newborn screening, since when the newborn screening result comes out, it says presumptive positive, since it still requires a confirmatory test. So unfortunately, some providers may think this is actually a carrier status when it's not. So as we mentioned, it identifies patients with SMA because of the SMN1 deletion. So again, the wording can be sometimes confusing to providers who are not familiar with it. So moving on from SMA to Duchenne muscular dystrophy, again, this is the most common type of muscular dystrophy. It affects boys. We know it causes a progressive weakness. Usually the patients come with clinical findings such as delayed development, proximal muscle weakness, difficulty going up and down steps, and the Gower sign when they actually have to climb up themselves to stand up. And then if the clinical features are convincing enough to the pediatrician or the neuromuscular provider, then the first screening test that we did was a blood test to evaluate the muscle enzymes, which is called CPK or CK. And that is what is used for newborn screening for DMD. So it's not currently included on the national RUSP. Just the last we checked in the last meeting was September 2023. However, it has been discussed many times. And there are some states who implemented it, which includes Ohio, which was the first state to mandate newborn screening for Duchenne. There was a pilot trial in Ohio, and this may have led to the fact that this was implemented there. There are also pilot programs in New York, Massachusetts, and North Carolina, and they're testing the feasibility of widespread screening. So they have to prove that actually the test is reliable, that it can pick up most of the patients with Duchenne, and that it's easy to provide and to interpret. So because now in most states we rely on the clinical findings, as I mentioned, then once we do the screening, which now is clinical, which is the blood level of the creatine kinase or CK, then we have to do genetic confirmation. And the genetic confirmation of the disease includes certain techniques such as DMD PCR or something called DMD array, which can detect most of the mutations on Duchenne, which includes deletions or duplication mutations. Now, occasionally, these techniques will not pick up the mutation, so we have to resort to something called gene sequencing, which can detect small insertions or deletions. Very rarely we resort to muscle biopsy now because there are still mutations that are not picked up on some of these techniques for one reason or the other. But again, it's a technology, and sometimes the muscle biopsy will provide us with pathological findings, which includes the absent dystrophin based on the staining, and that can confirm the diagnosis of Duchenne. Unfortunately, though, the muscle biopsy will not tell us where is the mutation on the gene. So there are some missed cases in Duchenne because, again, the Duchenne can present challenges to newborn screening relative to SMA because it's such a large gene, and we'll talk about it in a minute. But also knowing what to look for can help reduce the odds of a missed opportunity. So if the patient has the clinical findings to suspect Duchenne, then the first screening, as I mentioned, is a CK-based screening. However, if in the newborn screening, if the CPK level cutoff is lower than what the patient presents with, then it can be missed and may not be flagged as positive. So the cutoff limit can sometimes be debatable because there is some muscle breakdown when the baby passes through the birth canal. So that can elevate the muscle enzymes in general in any baby. So now is the cutoff is a 500 CPK, 600, 1,000. So sometimes this can create some missed cases. Now, whether or not to the confirmatory genetic test, is it what's called next generation sequencing, which is a very highly sophisticated genetic testing. However, it is expensive, or implementing a cheaper or less sensitive test like a DMD array or PCR. So again, this can be confusing depending also on what each state may choose to implement from a financial point of view. There are some unusual mutations that can be missed depending on sequencing, and that includes intronic mutations. So we have patients who actually had these intronic mutations. Clinically, they look like Duchenne. We did all the common testing. The CPK was markedly elevated, so we knew it most likely is Duchenne. They're boys. We did the PCR. We even did the gene sequencing. However, the intronic mutation was picked up on the DMD array. So we had to go through 3 different levels, and because it was an unusual mutation, actually one of the patients ended up having a muscle biopsy to even confirm the diagnosis based on the staining. Now, there are some panels that are apparently being offered also for pregnant women, which can identify some DMD mutations. However, there are some DMD mutations now that we're recognizing, especially that we have more and available genetic testing and more readily available access to it, that sometimes is free of charge. That there are some presumptive positive mutations on the DMD gene, however, that they do not present even later on in life with any manifestations. So it can be difficult to interpret what is the phenotype that's going to present with these unusual mutations. And it can be possibly distressing and also difficult, even from a clinician point of view, to predict if the patient is going to have Duchenne or not. So this is something to put into consideration, because my understanding these prenatal testing are becoming more and more available. So there are challenges, as we mentioned, in the DMD genetic causes or testing, and that's because it's the largest gene in the human genome, and it's usually prone to high spontaneous mutation rates. But we know that 30% of the patients will not have a family history. If there is a family history and the baby has the clinical manifestations, then it's easier to come to a conclusion earlier that this is Duchenne. So there is a high spontaneous mutation rate, and most mutations are whole exon deletions. So those are easier to pick up on most genetic testing techniques. There are also hotspots, and that's what the PCR picks, is 45 to 53 exons. So it can be missed if you have a mutation outside of this, the hotspot, then it can be missed if you only perform the PCR. Now we have to understand what's the difference between Becker's and Duchenne. Becker's is the milder form, and Duchenne is the more severe form of the dystrophinopathy, or Duchenne and Becker muscular dystrophies. So what's called an in-frame mutation, meaning it keeps the frame and it allows the body to read the exons and to provide and to actually transcribe the protein, which is the dystrophin. However, in the Duchenne patients, it's usually an out-of-frame mutation, meaning it disrupts the reading frame, and it does not allow for any dystrophin to be produced. Now, there are other mutations like duplications, point mutations, intronic mutations, and something called stop codon, which can only be found on gene sequence. And the reason to try to find the exact genetic mutation is because we have different treatment options. So again, the large deletions can be missed, as I mentioned. Sometimes if initial testing is negative, but we highly suspect Duchenne, now we can do more testing to include intronic mutations, and also there are larger testing like exome sequencing. So there are pathogenic mechanisms for intronic mutations that are not very well understood for the DMD gene. Point mutations, as I mentioned, will require gene sequencing. And then some mutations in frame will be Becker or Duchenne, but some patients with in-frame mutations will behave like a Duchenne, which is more severe, and some patients with an out-of-frame mutation will behave milder, for like a Becker patient. So it's very hard to predict in the very early stages which way is the patient going to behave, whether it's going to be a milder form like Becker or a Duchenne. So that's why long-term follow-up and a close relationship with the neuromuscular specialist and the clinic is required. Now, we should discuss how we can manage these pre-symptomatic patients. So we did actually publish an article about, what to do when a patient is diagnosed on newborn screening. So first, we'd like to review the newborn screening results with the family and try to explain to them what this disease that they may never have heard of. What is the neuromuscular clinic, what is the schedule of follow-up, whether or not there is psychosocial support that is needed, and also meet with the genetic counselor. Of course, the patient has to be looked at as a whole, so feeding, sleeping, elimination, growth parameters, and also cardiac and motor assessments will be performed in the clinic. Discuss with the family if they have any questions, discuss routine issues such as immunizations. And then usually the recommendation for follow-up visits are between 6 and 9 months, 15 to 18 months, and 24 to 30 months to also monitor the development. In the interim history, there are parameters that we look for in any patient, but more so in patients who are identified with Duchenne muscular dystrophy, such as growth parameters, cognitive assessment, which can be affected, and then to discuss with the families any concerns and to adhere to the immunization schedule. So some treatment options that are available that we can discuss after a newborn screen is identified in Duchenne include treatment options such as that can be geared towards certain mutations, which like exon skipping mutations, which can only be offered to certain mutations, and can be restricted to age, how severe is the manifestation in the patient, how far advanced is the disease, whether or not it's actually going to have any benefit if the disease is far advanced. Gene therapy, which has just recently become available. So this can be discussed as well, and it's very promising. However, it is restricted by age, and also, again, antibody testing to the vector or to the capsule that carries the gene. So if the patient has high titers, then the treatment would not work and would be none. And of course, there are some guidelines for steroids or a treatment that is not mutation specific. So steroids have been used for a long time. However, some parents, of course, may have concerns about the side effects, and it can be sometimes restricted by age or how early diagnosis is made. So there is the benefits of early identification, other than providing treatment option, is to plan for care, provide a multidisciplinary approach to the disease, and frequent follow-up to identify complications and connect to care specialists and also subspecialists such as orthopedics, PM&R. So we can go to the next slide, because it's a multidisciplinary care and it's a disease that affects all aspects of the body. So it requires all the specialists and people in the community, industry, and advocacy groups to come together to care for the patients with Duchenne muscular dystrophy. So we know that the treatment strategies continue to evolve, and that is even more of a reason to continue newborn screening and to provide newborn screening for Duchenne, because there's gene replacement therapy. The first one was approved, but there is actually 3 or 4 down the pipeline. There's more exons that can be amenable to exon skipping other than the ones we have available today. So there was more treatment options that can be available for other exons, and also hopefully for other treatment options that can provide treatment for a subset of patients who have stop codon read-through. In addition, there are even other approaches to the treatment of Duchenne, including anti-inflammatory medications that help improve other proteins that can substitute for dystrophin or the dystrophin deletion. So we have to be hopeful in that there is more treatment coming down the road. Even if today the newborn screening may identify a patient, we may not have a treatment option for some of the patient subsets, but however, there is more to come. Now, we did actually look into whether or not newborn screening can change patients' and families' perspective of newborn screening. So this study actually looked at parents who were expectant, and 92% of parents, who did not even know that there is an entity called newborn screening were agreeable, and about 95% of patients who already have a history of Duchenne or Becker or SMA actually were in favor of implementing newborn screening for these diseases. And we know that we actually had a pilot trial here at UPMC Children's Hospital, and we looked back 20 years later at the patients, and there was a strong support for newborn screening for the patients who were identified 20 years prior. And also, there was no evidence of any psychosocial impacts on patients who were early identified. If anything, they may have like future planning and to anticipate the complications that can accompany the disease. So some considerations is actually that most experts will support the use of genome sequencing or bigger panels even for other diseases, not just neuromuscular diseases. And this, especially in diseases that have treatment. So do experts endorse sequencing of newborns to screen for treatable genetic disease? This was the question, and which genes to be screened for. So about 238 rare disease experts were surveyed, and their attitudes towards using genomic testing for rare disease was very positive. So 88% felt that this should be available to all newborns, because the earlier we identify any progressive disease, especially if there's a treatment option, then definitely we can offer the treatment. But even so, if there's no treatment options, this at least can help the family avoid any anxiety that can accompany the undiagnosed patient, and also, going through several specialists sometimes to reach a diagnosis. So DMD was actually included among 25 genes that were identified by screening, and this was found by at least 85% of the experts.
So on the screen here, you see select publications that were mentioned throughout the presentation. Some blog posts that covered, what's in the news regarding newborn screening, and then some online links and tools that are available for you should you want to learn more. And then if you're not already signed up to receive the medical education team's monthly report, you can use that QR code on the screen or contact us at the address listed there. And then on the left-hand side, you see some upcoming events that we've got in full gear kicking off shortly, including our annual conference coming up in March. And I still see, yep, no additional questions. So with that, we'll wrap it up and say thank you to you all for attending, and thank you, Doctor, for providing us these updates.
Thank you so much.
Have a good day, good evening.
You too. Bye, everyone.